Okay, good afternoon, ladies and gentlemen. Thank you for attending our HIPS APASL webinar this year. My name is Jim Mo Yang, President of APASL. Today's topic is mechanism and the non-invasive assessment of liver fibrosis and the steatosis. As you know, among liver disease, hepatitis B and C patients are decreasing with effective antiviral treatment. Fatty liver and alcohol patients are gradually increasing. Unlike hepatitis B, cirrhosis is diagnosed when steatosis or alcohol is the cause, but it is often difficult to diagnose with a blood test or abdominal ultrasound. In evaluating the degree of chronic liver disease, the presence of cirrhosis and the prognosis of cirrhosis, fibroscan is a relatively simple and valuable diagnostic method compared to other examination methods such as liver biopsy and MRI. Today, I'd like to invite Professor Sarin and Professor Castell as the expert professor in this field to hear their opinions. Let me tell you one good news. It said that the number of participants in the APASL webinar on YouTube is more than 1,000 participants, which is more than the number of participants in the ASLD webinar. I'd like to take this opportunity to sincere thanks Professor Young-Sung Lim from Assam Medical Center, the chairman of APASL webinar committee, and everyone who attended the APASL webinar. Thank you to everyone who has always been interested in APASL webinar. Finally, I'd like to introduce today's webinar moderator, Professor Sarin and Professor Castell. Professor Sarin is a senior professor, hepatology and the director, Institute of Liver and Biliary Science, ILBS New Delhi. He was setting up the ILBS under the government of Delhi. He is also the director, WHO Collaborative Center on Chronic Liver Disease and Hepatitis at ILBS. He has more than 600 publications to his credit, edited 13 books on liver disease. He has helped develop 19 major guidelines. He credited with several new treatment protocols for liver disease, especially peripheral bleeding, liver regeneration, hepatitis B, and ACLF. He also got many awards: Shanti Shrub Patnagar Award, the World Academy of Medical Science International Prize, EASL International Recognition Award, Om Pakas Basin Award, Dambantri Medical Award, and so on. And also he's the editor of Hepatology International. And I'd like to introduce another moderator, Professor Laurent Castell. He's the professor of hepatology at the University of Paris and the visiting professor of medicine in University of College of London. His research interests focus on non-invasive method for liver fibrosis assessment, Nafld, and hepatitis. He has published more than 180 papers in international peer-reviewed journals and also serves on the editorial boards of the Journal of Hepatology, Garden Liver International. He has been the chairman of the first international guidelines on the use of non-invasive tests, and he has served EASL Vice Secretary from 2013 to 2015, and the EASL Secretary General, same as the EASL President, from 2015 to 2017. Thank you. Professor Sarin, please.
Thank you, Professor Jomin Yang, our president of the APASL. It's a great pleasure to join this very important session along with Laurent Castell, who is an authority. APASL webinars are very popular, thanks partly to the APASL name and partly to our dear colleagues from Korea and also George Lau, who worked in the last 1 year along with the group from Thailand, Dr. Tanwandi, to make it popular. And on behalf of Masao and myself, we thank all the speakers for today's program. I will not take more time except to say this is a very important session. We, in our practice today, use both spleen and liver stiffness. We are using more and more non-invasive tests, and also try and see whether there is an effect on fibrosis or effect on the biochemistry or even liver biopsy. ILBS, we do close to 1500 HVPGs and about 700 transjugular plus HVPGs every year. So we have an opportunity of learning from these, and it's amazing how you can replace the invasive with non-invasive methods. So I congratulate your team, and I would like to start without wasting more time, and maybe others can be taken up by Laurent, is to start on the first case presentation, a case of chronic hepatitis B who initiates antiviral therapy, and this will be picked up from Yonsei University by Professor Kim.
It is a great honor to participate in this APASL webinar together with the distinguished chairman and other speakers. I will introduce the case of a patient with chronic hepatitis B who initiated antiviral therapy. I have no COI regarding this presentation. Part 1, Case Presentation. A 46-year-old man was referred because of elevated liver enzymes and liver cirrhosis on ultrasonographic evaluation in a primary clinic. He was aware of having chronic hepatitis B virus infection since he was young. However, he had not previously visited a hospital for chronic hepatitis B, mainly because he had no subjective symptoms. His platelet count was 120,000 per microliter. The prothrombin time and total bilirubin and serum albumin levels were within normal range, but his liver enzymes were slightly elevated, HBe antigen was positive, and HBV DNA was 50,000 IU per L. His BMI was 23. His liver stiffness was 18.2 kilopascal, suggestive of liver cirrhosis. The patient had mild fatty liver based on his CAP value. Similarly, liver cirrhosis was highly suspected based on ultrasound finding. Thus, the diagnosis was compensated liver cirrhosis caused by hepatitis B virus. Antiviral therapy was initiated. Question: what is the diagnostic accuracy for liver fibrosis and steatosis of non-invasive surrogate? How can we predict the risk of HCC development at initiation of and during antiviral therapy? Can non-invasive surrogate monitor the changes in fibrosis and steatosis during medical interventions? Thank you for your attention.
Would you like to answer these questions or yourself? Are you posing these questions, Dr. Kim?
These are just a question. So please proceed with the presentation.
You are going to proceed with them now?
After the presentation, I will summarize the progress and.
Okay.
Thank you, Chairman. It is my honor to present today here. Thank you for inviting me. Today's my talk is basic mechanism of liver fibrosis and in chronic hepatitis, grade and the stage are main features, and the grade is inflammation and fibrosis is a stage. And how to assess the fibrosis stage? Here are classical scoring system including Nodal, Shoya, Ishak, Metabia, and the Korean study group. And I think you are very familiar with these staging systems. In these staging systems, all are based on the following conceptual stages and differ only in how they are subdivided. 0 is no fibrosis, 1 portal fibrosis, 2 periportal fibrosis, 3 septal fibrosis, 4 is cirrhosis, and actually cirrhosis is the end stage of fibrosis. Here, Ishak subdivided in the 6 scoring system, Metabia and Nodal subdivided in the 4 scoring system. Here is the pathologic features: no fibrosis, portal fibrosis, periportal fibrosis, septal fibrosis, and cirrhosis. And actually, fibrosis is a continuous progress of liver disease. In cirrhosis, is characterized by regenerative nodules and fibrous septa. And the cirrhosis is not a homogeneous stage. Actually, there are compensated and decompensated stage, and cirrhosis shows various clinical severity and prognosis. These features are morphologically all cirrhosis. However, in this case, the fibrosis is mild, and in these cases, the fibrosis is marked. So, histological subclassification of cirrhosis, so-called Lennox staging system, have been suggested. In this subclassification, they divided in cirrhosis 4A, 4B, and 4C. 4A is mild fibrosis with thin fibrous septa. 4B is moderate cirrhosis at least 2 broad septa. And 4C is a severe cirrhosis, at least 1 very broad septa, or many minute nodules. And our colleagues evaluated this Lennox staging and portal hypertension grade. They evaluated 123 cases, and the major etiology are alcoholic liver disease. They measured the hepatic venous pressure gradient, and 4A, 4B, 4C shows a significant difference. And the functional stage of cirrhosis, child class score, MELD score are also significantly different. Severity of varices, extent of ascites, frequency of esophageal variceal bleeding, and the clinical stages are all significantly different among 4A, 4B, 4C. Therefore, this Lennox system suggested to represent more functional stage of liver cirrhosis. Our group also evaluated the usefulness of Lennox staging for stratification of prognosis in patients with liver cirrhosis. Here is the morphometric analysis of stage 4A, 4B, and 4C. Liver fibrosis thickness is more thicker in stage 4C, and the nodule size is smaller in stage 4C compared to 4A and 4B. And the fibroscan data are significantly different to stage 4A, 4B, 4C. However, the fibroscan data was not significantly different among stage 3 and 4A cases. And we compared the liver-related events defined as cirrhosis-related complications, including hepatic decompensation, Hcc, and viral-related deaths. And these instances are significantly different between 3 and 4A group and 4B and 4C group. And the cumulative incidence rate of liver-related events are significantly different among stage 4A, B, C, and stage 3. So, Lennox staging represent prognosis of liver cirrhosis. We also check the histological subclassification of liver cirrhosis can predict recurrence after curative resection of HCC patient. And most patients are Hepatitis B related HCC patient with Lennox stage 3 to 4A. Cumulative incidence rate of HCC recurrence are significantly different among stage 3, 4A, 4B, and 4C. And the rate of recurrence instances are different stage 3 to 4B cases compared to 4C, and the cumulative survival rate are similar patterns. Therefore, Lennox staging can represent the prognosis of liver cirrhosis. How about the dynamic change of liver cirrhosis? Actually, there are progressive fibrosis and regressive fibrosis. And the liver fibrosis is a net result of dynamic change between fibrosis and fibrolysis. Here is a portal fibrosis, periportal, septal, and liver cirrhosis. There is a progressive fibrosis. However, there are also regression of liver fibrosis. Probability of liver fibrosis regression depends on the stopping of injury and the degree of fibrosis before the injury is halted. Hepatic stellate cells are important for liver fibrosis. There are different forms of hepatic stellate cells: quiescent form, activated form, and inactivated and senescent form. Quiescent form is a lipid vitamin A storage cells are located in the space of the cell. When it is activated, it turns as a myofibroblast, and it is fibrogenic cells. Myofibroblasts can proliferation, contraction, chemotaxis, and fibrogenesis. And the activated Kupffer cells release cytokines. They promote proliferation, contraction, chemotaxis, and fibrogenesis. And the inactivated and senescent cells are related to fibrosis regression. And the macrophages are also important in fibrosis. These cells promote fibrogenesis by secretion of TGF-beta and other agonists. In addition, these cells also support the regression of fibrosis through secretion of collagenases that resolve the fibrous scar. Here is the process of chronic liver disease. Injury occurs, and the hepatocyte inflammation and the macrophages are activated, and the hepatic stellate cells are activated and proliferate, and fibrosis occurs. And the underlying cause of injuries are stopped. The fibrosis regression by apoptosis of stellate cells, inactivation of stellate cells. These stages are progressive fibrosis, and these are regressive fibrosis. And here is the schematic drawing of progression and regression of chronic hepatitis. Here is normal parenchyma, and the inflammation occurs. It shows early parenchymal extension with the inflammation, macrophages, activity of the hepatic stellate cells, and the minimal collagen deposition. And the progression of parenchymal extension showing increased deposition of collagen with the fibrous septa and the prominent stellate cells. In quiescent stage, the fibrous septum is well formed and dense, and the inflammation is decreased. And the regression stage, the fibrous septa is more compacted, acellular, and fragmented. In some cases, there is a complete regression of fibrosis. However, in the cases, we can see distortion of parenchymal anatomy, suggesting previous liver injury. How we can define regression of fibrosis by histopathological features? There are delicate perforated septa, delicate periportal fibrous spike, hepatocytes within or splitting septa. Scattered collagen fibers within the parenchyma represent regression of fibrosis. Here is the example of chronic hepatitis trichrome stain, and the blue color represents fibrosis. Here, the fibrous septum is not continuous. It is thin, condensed, and there is a perforated point. In the higher power, the perforated fibrous septa is perforated by regenerating hepatocytes and the hepatocytes within the splitting fibrosepta. These are features of regressing fibrosis. Here is another cases. The fibrosepta is scattered and thin, not continuous. And this thin perforated septa, you can see hepatocyte regeneration. And recently, more qualitative assessment of fibrosis scoring system is suggested, so-called progressive, indeterminate, and regressing scoring system. In this system, predominantly progressive represent most fibrous stroma showing wide, broad, loosely aggregated collagen fibers with inflammations and macrophages and ductal reactions. These loose and thick septa are progressive septa. Predominant regressing feature shows most fibrous septal stroma with a thin, densely compacted and largely acellular stroma. These thin, dense fibrous stroma is regressive features. Indeterminate scoring, ratio of progressive and regressing scaling appears balanced, neither one clearly predominating. Here is a mix of progressive, regressive, and progressive and regressive fibrous scoring. And the Beijing group compared the PIR scoring system in chronic B viral patients before and after treatment. They compared 71 pairs of liver biopsy. Here is a pre-treatment and post-treatment feature. In predominant, mostly progressive features, and post-treatment and mostly regressive features. And they compared the PIR scoring and ESHAC staging. In decreased ESHAC scoring systems, they are mostly regressing features, and increased ESHAC scoring systems mostly progressing features. In cases of stable, no change of ESHAC fibrous scoring, when these cases are evaluated PIR scoring, mostly show reversing features. Actually, these cases show significant improvement in terms of Lennox substage, collagen percentage area, and the liver stiffness score. So, regressing features are well correlated to other parameters of fibrosis regressing. And the PIR fibrous scoring is compared Lennox staging, and the predominant regressive features are mostly Lennox 4A. In contrast, the predominant progressive features are mostly Lennox A or B or C. Indeterminate are Lennox 4B. So there is some correlation between PIR fibrous scoring and the Lennox scoring. We also evaluated one-time assessment of PIR staging. In clinical practice, 2 times biopsy is very hard and almost impossible. So we checked the significance of one-time assessment. At the time of curative resection of B viral HCC patient living antiviral treatment, we evaluated PIR staging, and we found that cumulative incidence of late recurrence is related to the regressive feature of PIR staging pattern, and the HBV DNA levels are also related. So one-time assessment of PIR staging can predict the outcome of B viral patient. How about the parenchymal regeneration related to liver fibrosis? These are liver cirrhosis, and when you have a microscopic examination, you can see 3 kinds of cellular change of hepatocyte. Most hepatocyte shows senescent change, and there are dysplastic change of hepatocyte, including small and large liver cell change. And the small liver cell change is a precancerous region. And there is also hepatic bud represent progenitor cell proliferation and hepatocyte regeneration. We studied epicam positive hepatocytes is a newly developed young hepatocyte from liver progenitor cells in human livers. Here is the epicam staining in portal fibrosis stage 1 and cirrhosis in stage 4. And we compared epicam positive cells. These cells are small amount in stage 1. However, we can see many epicam positive cells in liver cirrhosis stage. Here is the data, and the epicam positive hepatocytes are significantly increased with the progression of liver fibrosis. And we checked the telomere length in cirrhosis, bile duct ductular reaction, and the epicam positive hepatocyte in normal liver hepatocytes of canal of herring and bile duct. And the pink signal represent epicam. Here is the telomere length in cirrhosis. Ductular reaction represent the liver progenitor cell compartment, shows the longest telomere length, and the epicam negative hepatocyte shows the shortest telomere length, and the epicam positive hepatocyte shows intermediate length between ductular reaction and the epicam negative hepatocyte. Therefore, epicam positive hepatocyte is a newly developed young hepatocyte from the liver stem progenitor cells representing liver regeneration. Actually, hepatic repair complex includes fragmented and regressive fibrous scar, and parenchymal regeneration of hepatic bulge, and evidence of prior now resolving vascular derangement. Here is the example of a hepatic repair complex. The fibrosis is thin and fragmented, and this vessel, probably centrovenule, is patent, however, too close proximately to the septum, showing typical feature of vascular distortion at advanced stage of liver fibrosis. And we checked the liver regeneration after curative resection of HCC by evaluating epicam positive hepatic bulge and PIR fibrous staging system. Non-tumoral livers from HCC patient who underwent surgical resection is evaluated, and the liver volume was measured at post of 7 and 90 days using computed tomography, and the liver regeneration ratio was measured, the ratio of liver volume 90 days per liver volume 7 days post-operation days. Here is the epicam positive percentage and PIR staging. Interestingly, regressive stage 4 shows the highest number of epicam positive cells representing hepatic bulge. And liver regeneration was compared to fibrous staging, and for regressing stage shows a higher liver regeneration compared to for indeterminate and progressive fibrous staging. And the fibroscan number is well correlated by liver regeneration rate. So PIR staging are considered to represent liver regeneration and well correlated with the Fibrosis score. So here is the summary. Liver fibrosis is net result of dynamic changes between fibrogenesis and fibrolysis. In this new area of successful treatment of B viral and C viral chronic hepatitis, more fine quantitative and qualitative scoring system of liver fibrosis is required. Histological subclassification of liver cirrhosis, so-called Lennox staging system, and the PIR scoring system represent more functional evaluation of liver fibrosis. Actually, these scoring systems represent liver-related events, parenchymal regeneration, and late HCC recurrence, etc. These scoring systems are considered to be useful assessment of clinical trial as well as daily practice. The possibility of applying this concept to other diseases, including Nash and alcoholic hepatitis, is expected. Thank you for your attention.
Thank you very much, Professor Park, for this excellent lecture. Now we have time for a few questions from the audience. Any question?
Yeah, may I raise the questions about these subclassifications and with the new fibrosis regressions recognitions? How well is it validated in the clinical setting? I want to hear, because we have troubles of getting drugs registered for liver fibrosis, and I just wonder whether these new classification or subclassifications would be helpful in helping us to move forward, and whether there is large enough data for the prognostic implications with these subclassifications.
I presented the data of chronic viral hepatitis, including hepatitis B, mainly B. And the reason we can investigate these cases, we have a biopsy, enough number of biopsy cases. And the interesting point is stage 3 and stage 4B. Stage 4A. Stage 4A is a cirrhosis, but usually have a regressing feature. So total amount of fibrosis seems to be same, stage 3 and stage 4A. So the FibroScan data has no difference between stage 3 and stage 4A in our data. However, structurally, it is different. 4A is it was cirrhosis and then regressed features by histological evidence. So like this study, we can tell it is a progressive fibrosis or regressive fibrosis. And the Beijing data is very interesting because they have a 2 times biopsy before antiviral treatment and after antiviral treatment. So it is a very rare important data to prove the liver progression, fibrosis progression and regression in human data. And one point I would like to mention is this viral hepatitis fibrosis is a portal-based fibrosis. However, in Nash, alcoholic congestive hepatopathy is a zone 3-based fibrosis, usually very thin fibrosis along the sinusoid. And that kinds of fibrosis, we need more work to prove regression or progression. We don't have enough data about these central sinusoidal fibrosis disease. So we need more work. I think that is one of the reasons we have a very hard time to proving the new drug trial for Nash treatment.
Thank you very much.
Thank you very much, Professor Park. Any other questions?
I have a question to Professor Park. Very interesting lecture. Thank you very much. How accurate is the discrimination between progressive and regressive fibrosis?
Yeah, that's a good question. I think there is not so many data evaluating the progressive and regressive data. I think the Beijing data is reliable because they have 2 paired cases and the number is 75. And in our group, evaluated this PIR system using one-time assessment. And I already presented our data. One-time assessment of PIR system can predict the late recurrence after curative resection of HCC. And also these regressive features can predict the liver regeneration. And actually this concept is not the new one. Beginning period of antiviral treatment of hepatitis C virus, the clinicians started to experience the fibrosis regression, and from that time, there is evidence is piling up the fibrosis regression features. So it is a very well concepted idea among the pathologists, and I think it is pretty reproducible. And now we highly recommended to include these progressive and regressive features to the liver biopsy data. But in these days, there is rapidly
decrease of liver biopsy for viral hepatitis. So that is the reason there is no active external evaluation.
Thank you very much.
Thank you.
Thank you very much. If I may add a comment, at our center, our pathologist is Professor Paradis, that you probably know. And she's very fond, Valérie Paradis.
Okay, please give my hello to her.
And she is very fond of the Laennec classification. And actually in the literature, there's not many papers. Yours is highly quoted in Hep B, but there are very few papers, to my knowledge, in Nash and alcohol. We have some data actually showing similar trend as you've shown in hepatitis B, with a very good correlation with HVPG, liver stiffness, and Laennec classification in patients with alcoholic or Nash cirrhosis. This is not yet published, but
yes. Very good to know that, because we don't have a good evidence, good high number of data about the alcohol and Nash. So good to hear your data.
But still in the everyday clinical practice is not widely used. And of course, people perform less and less liver biopsy, especially in cirrhotic patients. So we don't really have this data. And also to answer the question of George, in most trial, in NASH, for instance, cirrhotic are usually excluded, and especially if they have decompensated cirrhosis, previously decompensated. So they're usually cirrhotic with no decompensation and no portal hypertension. So it will be very difficult to get this data. But still, I'm quite convinced this is very important, because if you reach Laennec stage C, it's very unlikely that you can regress, because your fibrosis is cross-linked like this.
Yeah.
And even though you stop drinking, you cure Hep C, right, be very unlikely to regress.
Yes.
Okay, thank you very much again. I think we'll move to the next presentation that is actually mine. So I will not introduce myself, and I will move to the slide. Okay, can you see my slide?
Yes, very well.
Okay. Okay, so first of all, I would like to thank the APASL and the organizer for the kind invitation. My task within the next 20 minutes will be to deal with non-invasive assessment and monitoring of liver fibrosis. These are my disclosures. So, as you know, non-invasive tests are now ready for prime time. And they basically are based either on the dosage of serum biomarker, some not patented, just like FIB4 and NFS that are the most popular. And regarding the patented, FibroTest was the pioneer in Hep C, but now ELF is becoming the more popular one and the most validated. As for elastography, as you all know, vibration-controlled crescent elastography, better known as FibroScan, has been the pioneer, but we have other techniques, including RFI, 2D shear-wave elastography, and lastly, MR elastography. Don't forget a critical issue when you're using this test is, of course, availability, and FIB4 and NFS are widely available, whereas MRE is not widely available, and this, of course, comes also with cost. So, well-known confounder of liver stiffness in clinical practice, obesity, and need to use an Excel probe if your BMI is above 30, especially Nafld. And of course, inflammation is another source, and especially in Hep B, of false positive. I just want to stress that there will be a recent update of the APASL guideline on non-invasive tests that are now published in the September issue of the Journal of Hepatology, and I will refer to them. I will also focus mainly my talk for the sake of time on Nafld, because this is where the field is going, and this can also be applied to alcoholic liver disease. So there will be two-part assessments of liver fibrosis and monitoring of liver fibrosis. So as I mentioned already, in Nafld advanced fibrosis, F3, F4 is the endpoint because these patients are the most at risk of complication and death in terms of not only liver-related mortality, but also overall mortality. So this table summarizes the result of Nafld fibrosis score, FIB4 and ELF, meta-analysis, large number of patients, as you can see. There are different meta-analyses, so you cannot compare head-to-head, but you can see the OROCs are pretty good between 0.78 and 0.83. However, in another study from the STELLA trial, where there was head-to-head comparison between these three markers, you can see that ELF slightly outperformed NFS and FIB4. However, widespread application may be limited by cost and availability of ELF. So this slide briefly summarizes the respective advantages and disadvantages of patented and non-patented tests. So FIB4 and NFS are simple and free, can be performed at bedside or in the outpatient clinic, widely available, acceptable accuracy, and high negative predictive value for the lower cutoff, more than 90% for advanced fibrosis, whereas they have modest positive predictive value. This is the upper cutoff, less than 70%. There are undetermined results in around 30% of cases, and age also should be taken into account, especially for FIB4, and cutoff should be adapted, upper cutoff. As for ELF, slightly higher performance, as I've shown before, and higher specificity, but less external validation and limited availability and cost. Now, regarding elastography, this is a summary of the different meta-analyses regarding elastography technique, and no surprise, transient elastography is the most widely studied. And as you can see, OROCs still are very good from 0.88 to 0.97 for MR elastography. However, transient elastography can be considered as a technique of choice in clinical practice for several reasons. First, because the evidence is Nafld is the highest. It also allows to measure steatosis with CAP, and this will be dealt with later on by Professor Wong. The failure rate, if you're using the XL probe, is below 5%. It's a point-of-care technique with immediate results, wide availability, and acceptable cost as compared to the other technique. I just would like to stress regarding the cutoff, because there are always discussions regarding the best cutoff. There are different strategies. And if you want to maximize sensitivity in this study, as you can see, so the cutoff would be between 6.5 and 7.1. So the negative predictive value is high, around 90%. But as you can see, the positive predictive value is too poor to be used in clinical practice. Now, if you want to maximize sensitivity and specificity, the so-called Uden index, then the cutoff would be between 8.6 and 9.7. Negative predictive value is still acceptable, and positive predictive value is better, but far from perfect, less than 65%. Finally, if you want to maximize specificity, then you need to increase the cutoff, and the cutoff is between 12 and 14. Negative predictive value, of course, is now much lower, and positive predictive value still reach around 70%. So the message is that as compared to viral hepatitis and especially HCV, the positive predictive value of transient elastography in Nafld is suboptimal. There is a recent real-world multi-center study with more than 5,000 CACLD patients with liver biopsy, of whom 1,000 have Nafld. And you could see in this meta-analysis that the proposed cutoff of Baveno, the 10 and 15 kilopascal, have been reconsidered and optimized. And if you lower the cutoff to 8 kilopascal, you increase sensitivity to more than 90%. And if you lower the upper cutoff of 15 to 12 kilopascal, still the specificity is very good, but you end up with around 30% of your patients in between this cutoff. Now, what is the best strategy in clinical practice? Now we have seen the efficacy, but how we are going to use them in practice. Either you paired your approach, or you have a sequential approach, biomarker then elastography, or biomarker then another biomarker. So the paired combination FIB4 and liver stiffness using transient elastography has been explored by an international group led by Salvatore Peta, 700 Nafld patients, tertiary referral center, and you see that if your FIB4 is below 1.3, liver stiffness below 8, the percentage of misclassified patients is very low, 3%. The issue is that you have a lot of discordant case between FIB4 and LSM, with indeterminate result in 54% of cases. And you end up with less than 40% of patients, 45% actually correctly classified. Another possibility is a sequential combination of two tests. The first test, simple, cheap, widely available with high sensitivity and negative predictive value, thus a FIB4, and a second test that is more specialized, still affordable, with high specificity and PPV, elastography or ELF. We have now a recent meta-analysis from the Litmus group that has just been published. And you can see that using this first strategy with a FIB4 cutoff of 2.67 as upper cutoff and liver stiffness between 8 and 10 kilopascal, you will end up performing liver biopsy in around 1/3 of your patients. A second strategy that is proposed by this group is to increase the upper cutoff of FIB4 and the upper cutoff of liver stiffness in order to catch also cirrhotic and to increase the positive predictive value of both tests for cirrhotic. And then the need for liver biopsy would be only in less than 20% of your patients. Finally, sequential combination, FIB4 and ELF. This has been tried in primary care in the UK, the so-called Camden-Ellington algorithm. 1,452 patients, they undergo first FIB4, and in the patient in the intermediate stage, ELF is performed, and this allows to have patients redirected to the low risk of fibrosis, and in the end, you have around 80% of patients with low risk of advanced fibrosis that can be managed in primary care. On the other end, the other 20%, referral is recommended. Have to just notify there was no liver or very few liver biopsy in this study. So these are the recommendation. The updated is a recommendation. The following non-invasive tests are recommended to rule out advanced fibrosis in clinical practice: liver stiffness by transient elastography below 8 kilopascal, ELF below 9.8, fibrometer below 0.45, or FibroTest below 0.48. And for non-patented, FIB4 is 1.3 and NFS minus 1.455. As for elastography, even though it's the most accurate non-invasive method for staging liver viruses, it's only marginally better than other NIT for advanced fibrosis and not recommended at first line given its cost and limited availability, and more suited to clinical trials. This is the algorithm that is recommended for clinical practice. Of course, you always check in patients at risk for chronic liver disease in primary care for liver risk factor. This includes viral hepatitis, of course, alcohol and metabolic syndrome, and you test for transaminase and platelet count. And in case of metabolic factor, you calculate first the FIB4. If it's below 1.3, you don't need to refer. You implement lifestyle modification, and of course, you can retest within 1 to 3 years. In case of value above 1.3, then you should try to perform liver stiffness either in the liver clinic or in primary care or diabetology clinic if it is available. Below 8 kilopascal, the risk is low and you don't need further investigation. Above 8 kilopascal, then this is intermediate to high risk, and you must consider liver biopsy according to patented serum tests. If they're available, you can combine and you will only perform liver biopsy in case of discordance. If they're not available, you could consider liver biopsy. Otherwise, advanced fibrosis is highly likely. Now, what about monitoring of liver fibrosis? So this study in 200 Nafld patients with spare liver biopsies, a retrospective study, is showing that NFS and FIB4 can detect fibrosis progression at least of one stage in Nafld. NFS and FIB4 can also predict complication and mortality in Nafld. This is a study from Sweden, large cohort with very long follow-up. But I just want to stress that the OROCs are pretty low, 0.72. ELF also, this is again the STELLA trial, can predict progression to cirrhosis at a cutoff above 9.7, and liver-related event at a slightly higher cutoff, 11.3. Prognostic value of liver stiffness is now well known in chronic liver disease. This is an old meta-analysis, mainly in viral hepatitis, with a large number of patients. And you can see that liver stiffness was associated with decompensation, occurrence of HCC, and mortality. More recently, specifically in Nafld patients, similar data have been reported in terms of complication and overall mortality. More interesting, because this is baseline liver stiffness, but we tend to repeat liver stiffness in clinical practice, and change in liver stiffness are also clinically meaningful, maybe more actually than only a single baseline measurement. And for instance, in this very recent study from Salvatore Peta, 563 Nafld patients with so-called CACLD, that is liver stiffness above 10 kilopascal, and repeated liver stiffness measurement with a median follow-up of 35 months. And you can see if your increase in liver stiffness over time is above 20%, the rate of liver decompensation occurrence was 10%, and significantly higher than if your liver stiffness is stable or is decreasing. These changes also are significant in terms of liver-related mortality, as shown on the left part of the slide, as well as on overall mortality. So these are the recommendation, latest recommendation: serum score, APRI, FIB4, NFS, ELF, and liver stiffness should be used to stratify the risk of liver-related outcome in Nafld. Repeated measurement of non-invasive tests can be used to refine stratification of risk of liver-related events in patients with Nafld. Despite the lack of evidence regarding the optimal time frame between subsequent liver stiffness assessment, it seems reasonable to repeat non-invasive tests every 3 years in patients with early stage and every year in patients with advanced stage of Nafld. This is a weak recommendation. Now, what about fibrosis regression? These tests have been shown to work well for fibrosis progression, but we don't really know for fibrosis regression. Most data we have so far come from the viral hepatitis field, HBV, HCV. We have this interesting study from the group of Massimo Colombo and our group. But as you can see, this is a highly selected population of 33 cirrhotic HCV patients with SVR and paired liver biopsy. And you can see that once they cure, the specificity of the usual 12 kilopascal cutoff is fine, but sensitivity is much too low for detecting cirrhosis. This is a meta-analysis in almost 3,000 HCV patients showing that liver stiffness decreased with SVR in HCV patients. However, there are many caveats of the studies included in this meta-analysis. They were mostly retrospective, with small sample size, many interferon-based treatment, short follow-up, and most importantly, no paired liver biopsy. Also, you have to take into account the viability of repeated liver stiffness measurement. This is a study from the group of Thierry Poinard. There are not many studies actually. 500 pair liver stiffness measurements within 1 year. And you can see there were quite viability, above 20% in half of the patients and above 50% in around 10% of patients. This is another study from Asia in HBV, showing that liver stiffness could not predict liver fibrosis regression on the nuke in HBV. And as you can see, this was performed in 300 HBV-treated patients, half of them with paired biopsy, with a long follow-up, week 78. And you can see that whether liver fibrosis progress was stable or regression, there was a decrease, but there was no significant difference between the groups. So viral hepatitis eradication or viral suppression is associated with decrease of liver stiffness over time. In the absence of paired liver biopsy, it's difficult to discriminate whether this is related to improvement in inflammation or fibrosis. And liver stiffness cannot be currently used as a good surrogate of fibrosis regression. Now, what about Nafld? We have very few studies so far. One study from the group of Rohit Lumba. You can see it's a small group of patients, 54 Nafld patients. This is MR elastography, biopsy at baseline and week 24. And although there was a decrease in liver stiffness in responder as compared to non-responder, still the difference was not significant. A very recent study, again from the same group, this is not MR elastography, but MRI-PDFF, with a more than 30% relative decline and the relationship with fibrosis improvement. And on the left side, you can see the odds ratio for fibrosis regression that is defined by fibrosis improvement of one stage. The odds ratio was above 6. On the right part of the slide, you can see the percentage of patients with an MRI-PDFF response according to fibrosis regression, 40%, fibrosis with no change, 25%, and fibrosis progression, 13%. So there are more patients with fibrosis regression, but it's not completely clear-cut. Recommendations: liver biopsy remains a reference to evaluate Nash resolution and liver fibrosis improvement and should be used for these purposes. Strong recommendation. And now these are my take-home messages. So FIB4, Nafld fibrosis score, ELF, FibroScan, and MR elastography are the most accurate and validated non-invasive tests for diagnosing advanced fibrosis in Nafld. In clinical practice, the optimal strategy is the sequential use of FIB4 and FS to rule out advanced fibrosis, ideally in primary care, then transient elastography using the XL probe in secondary care to rule in F3, F4. Non-invasive tests may be helpful to stratify the risk of liver-related outcome in Nafld, but have little value so far to monitor liver fibrosis regression, and further studies are needed. Thank you very much for your attention.
Thank you, Laurent, for this excellent presentation, and I hope there would be many questions to the presentation. They can all be put into the chat box while we are discussing. I only have one question. How do you factor in a rise in AST, ALT, which is very commonly seen in patients who have got Nash or any other liver disease? So can we factor inflammation in any way?
Sorry, I'm not sure I got your question. Is the influence of
the influence of inflammation, a high AST, ALT, how do you factor in any given assessment, non-invasive assessment?
So first, as you know, there are the usual rules. I didn't have time to mention, but if your transaminase are above 5 times the upper limit of normal, you should not interpret, for instance, elastography result, especially FibroScan, because there's a risk of false positive. But this is not usual. This can happen, of course, in hepatitis B, but not in Nash. Also, some of the biomarkers are using transaminase, such as FIB4, for instance, or NFS, and you have to be cautious. Also, as I've shown in Nafld, in contrast to what is observed in Hep C, the positive predictive value of liver stiffness is not that good. In other words, there are a lot of false positive. And this, in our practice, we have noticed. So liver stiffness can be used probably to stratify your patients and consider liver biopsy, but then liver biopsy should be considered on a patient-to-patient basis, according to whether it's going to change the management, whether you have a trial at your place and where you can enroll your patient. Otherwise, you will end up with some mistakes. I mean, for instance, a patient with 14 or 15 kilopascal, finally, after he underwent liver biopsy, is only F2 and not F3 or F4. So I think we have to be cautious. And there is probably, I mean, there is no clear explanation, but it's very likely that steatosis or inflammation, and there's always not a good correlation between the transaminase level and the inflammation you're seeing on liver biopsy, might be responsible for this. This is just a speculation, but I would be curious actually to get the advice of the panel regarding their experience with this.
Any other comments from the panel?
Yes, in fact, I want to throw questions to the panels and experts here. We have been talking about non-invasive measurements, pathology, and histology. I just wonder whether there is any more mechanistic studies in the serums in addition to these markers, such as the use of cytokines, IL-17 and so on, whether that would help to further improve, to understand the dynamics of the fibrogenesis versus fibrolysis.
There have been some studies, but there is many studies actually, but for the sake of time and also to focus, I choose to mainly mention the very simple tests that everyone can use and are widely available. But it's the same for Nash. There are many algorithm tests like CK18, but currently it's very difficult to make a good diagnosis of Nash non-invasively. So still, I believe that in the next future, we will not be able to perform liver biopsy in all our patients. First, because many will be reluctant. Then there will be so many patients that it will be impossible. So we will need to maybe find better strategies to stratify our patients and to end up performing a liver biopsy in a few of them.
And also in the recommendations you just presented to us, which is an excellent piece of work, do you have economic models behind the whole algorithms, the effectiveness from a public healthcare point of view?
Thank you very much for your comment. This is a very important issue, and you're right. I mean, these are more on the scientific side, but the economic side is very important. And especially what you're discussing with the payers, because everyone is convinced that FIB4 comes from nothing, is transaminase agent platelets. But then, of course, you have to convince the payers or the policymakers that this strategy is cost effective, which has not well been done so far, especially at a population level, for instance. And also, there's always the fear that there might be over-referral if you start to send to the liver clinic all your patients with FIB4 above 1.3. So the idea behind this recommendation was mainly, like it's been done in Baveno, to increase the awareness of our colleagues outside of our community. Because of course, we as hepatologists are very convinced that this test works. But when you're working with GP or endocrinologists, most of them have no clue about non-invasive tests, fibrosis, and this was the way to increase the awareness. And actually, I would be curious to have also your experience in Asia regarding this, because I anticipate that it's the same, you're facing the same issue regarding awareness.
Maybe Vincent can make a comment since Professor Vincent Wong is here.
Yes, thank you, Professor Lau. I agree with Professor Castell that awareness and also the clinical care pathway is an important issue. So nowadays in the hepatology clinics, we are still mainly receiving referrals because of severe steatosis on ultrasound scan or ALT elevation, but these are not good markers of severe liver disease. And therefore, there would be a mismatch between our capacity to provide care and also the kind of patients that most need our care. So in the future, I think a more logistic and also a more logical and also a common use of non-invasive tests hopefully will streamline this process.
Okay.
Thank you very much.
I suggest to move on. Sorry,
I agree.
in the interest of time. Thank you, Laurent, and maybe we have the pleasure of Vincent Wong, a professor, very well-known authority all over the world in the field of NAFLD. May I request you, Professor Wong, to start your presentation?
Thank you, Professor Sarin, for your kind introduction. Good evening, ladies and gentlemen. First of all, I'd like to thank APASL, especially Professor Yong-Suk Lim, for the opportunity to speak to you today. Here are my disclosures. My job today is to discuss the assessment of hepatic steatosis. Before we start, it would be good to ask ourselves why we want to detect steatosis in the first place. Above all, the diagnosis of Nafld, the most common chronic liver disease nowadays, is based on the detection of steatosis. Hepatic steatosis has a strong correlation with metabolic health. Because it can change rapidly with lifestyle intervention or pharmacological treatment, it may also serve as an early readout in clinical trials. We will have a more detailed discussion on this point later in this talk. Finally, even among patients with other liver diseases, such as chronic viral hepatitis, multiple studies have shown that the presence of metabolic risk factors and possibly hepatic steatosis is also associated with adverse liver outcomes, such as HCC. On the other hand, we also need to understand that among patients with fatty liver disease, steatosis has less correlation with adverse liver outcomes than the other histological features, notably fibrosis, that Professor Castell has just mentioned. This flowchart summarizes the latest APASL recommendation on the diagnosis of metabolic-associated fatty liver disease. Essentially, we can diagnose Nafld if a patient has hepatic steatosis and the presence of overweight, obesity, diabetes, or two other metabolic risk factors. How do we detect hepatic steatosis? There are four main methods: blood biomarkers or scores, abdominal ultrasonography, controlled attenuation parameter, and magnetic resonance imaging. In non-invasive test studies, investigators usually focus on diagnostic accuracy. However, we should also pay attention to their reproducibility as well as responsiveness. That is, whether the test can reflect changes in hepatic steatosis over time. This table lists the more well-known fatty liver scores, such as the Fatty Liver Index, Hepatic Steatosis Index, and the Nafld Ridge score. These scores typically comprise liver enzymes and metabolic risk factors that are derived using statistical logistic regression models or machine learning. On the whole, they have moderate accuracy for the diagnosis of Nafld. Personally, I don't find them useful in clinical practice And in fact, if you read the ESO guidelines that Professor Castell has just mentioned, it is also not recommended to be used in routine clinical practice. However, if you have a big cohort of patients and you want to study the epidemiology of Nafld, but don't have the imaging data, these scores would be an easy and inexpensive way to make the diagnosis. The downside of using these scores is the heavy influence of metabolic factors. When you find an association between these scores and clinical outcomes, it is impossible to tease out the individual effects of fatty liver and metabolic factors. In addition, we need to understand the caveats of the steatosis scores. The glycemic and lipid factors can be readily affected by treatment. For example, a score including cholesterol can decrease rapidly with statin treatment without any change in hepatic steatosis. Gamma GT is affected by alcohol consumption and biliary pathology. Bilirubin is affected by hemolysis, biliary pathology, and Gilbert syndrome, and white blood cell count can increase during infection or inflammation. In real-world practice, abdominal ultrasonography is the most common test for the diagnosis of fatty liver. Typical features of fatty liver include bright liver echo texture with high hepatorenal echo contrast, deep attenuation of the ultrasound signal, and blurring of the blood vessels. These features stem from the fact that ultrasound energy is dissipated more rapidly in a steatotic liver. In fact, Professor Hamaguchi from Japan combined these factors and came up with a score for a more consistent diagnosis of fatty liver. Even with a score, the diagnosis of fatty liver can be subjective and operator dependent. Therefore, manufacturers of ultrasound machines have been developing technologies to quantify hepatic steatosis. Most systems still depend on the attenuation of ultrasound signal, as mentioned earlier. Ultrasound-derived fat fraction by Siemens uses both attenuation and backscatter estimates. The latter represents how ultrasound waves are scattered in the tissue. Finally, the hologic system measures the speed of sound in the liver parenchyma extent. While all these mechanisms are interesting and potentially useful, more validation studies are certainly needed, and it is important to determine their reliability and intra- and inter-observer agreement. The audience is probably more familiar with controlled attenuation parameter measurement by vibration-controlled transient elastography or FibroScan. Again, this is based on the estimation of ultrasound attenuation in the liver. CAP was first evaluated in a cohort of patients with chronic hepatitis C. On the right, you can see a dose-response relationship between CAP values and steatosis grades, but there is also significant overlap in CAP values across steatosis grades. We are lucky to be involved in 2 individual patient data meta-analysis on the diagnostic performance of CAP using the M or XL probes. On the whole, CAP has good overall accuracy in detecting hepatic steatosis with an area under the ROC curve of 0.82 to 0.88. Nonetheless, similar to what was found in the original hepatitis C study, the overlap in CAP values means that it is difficult to determine the severity of steatosis precisely. Because CAP is good but not perfect, it is important to know when we can trust the results. In collaboration with Professor Victor de Leydegen from France and Professor Salvo Petter from Italy, we showed that the accuracy of CAP dropped when the interquartile range of 10 CAP measurements was greater than 40 decibel per meter. Our findings were confirmed by the UC San Diego group, but not by another multi-center UK study. However, I would argue that the UK study only included patients who had undergone liver biopsies for Nafld, so they didn't really have good controls without fatty liver for the evaluation of CAP. On the right, I'd like to introduce a new development called continuous CAP. In the past, we only took 10 CAP measurements. With a new technique called continuous CAP, CAP would be captured continuously whenever you place the probe over the liver. Although the examination time is the same, the machine would capture over 200 instead of just 10 cap values. As shown in this diagram, continuous cap did result in less variability and would theoretically be more accurate. More validation studies are needed. In contrast, MRI can be considered as the gold standard to measure hepatic steatosis. There are two main MRI techniques, MRI proton density fraction or PDFF and proton MR spectroscopy. As shown on the right, the two techniques essentially yield identical liver fat fraction values and are equally reproducible. Because MRI PDFF examines the entire liver and is cheaper to perform, it is preferred over proton MR spectroscopy nowadays. Compared with ultrasound-based assessments, MRI is not affected by obesity and ascites and is more accurate. Cost and availability would be the main barrier to its wider adoption. It is noteworthy that histologic assessment of hepatic steatosis is rather crude based on the percentages of steatotic hepatocytes at cut points of 5, 33, and 66%. In this interesting study by Mazen Nuruddin and colleagues, changes in MRI PDFF in the Mozart trial correlated with improvement in body weight and liver enzymes, and such correlation couldn't be captured by histologic steatosis grading. This suggests that MRI PDFF is more sensitive than histology in picking up small changes in hepatic steatosis. If we can measure and monitor hepatic steatosis accurately using MRI PDFF, the next obvious question is whether this carries any clinical meaning. Using the Mozart study again, Rohit Lumber's group showed that patients with MRI PDFF reduction were more likely to have a 2-point improvement in the Nafld activity score. This is a meta-analysis published in CGH last year. Patients with an MRI PDFF response defined as a more than 30% relative reduction in MRI PDFF were 7 times more likely to have a 2-point reduction in the Nafld activity score and 5.5 times more likely to have resolution of Nash. Recently, the UC San Diego group further showed an association between MRI PDFF response and fibrosis improvement outside clinical trial setting. Thus, the MRI PDFF response is an attractive and biological plausible surrogate marker of treatment response. Of course, one would expect that the meaning of MRI PDFF response is drug-specific. It may correlate with histologic response better for drugs that have a potent effect on liver fat. Examples would include inhibitors of de novo lipogenesis, such as acetyl-CoA carboxylase inhibitor and fatty acid synthase inhibitor. In contrast, the MRI PDFF response is probably less relevant for anti-inflammatory and anti-fibrotic drugs that don't have a direct effect on liver fat. However, this view is still too simplistic. It turns out that the MRI PDFF response may not work well even for some metabolic drugs. At the virtual EASL meeting in June this year, Japanese investigators led by Professor Nakajima showed that the new PPAR alpha agonist, pemafibrate, reduced liver stiffness and ALT, but not MRI PDFF. Last year, Ken Kusi's group showed that the MRI PDFF response didn't correlate with histologic response in patients treated with pioglitazone. The Florida group also showed an interesting finding. Although MRI PDFF response didn't correlate with histologic response in both the pioglitazone and placebo arms when analyzed separately, a correlation was seen when they combined both groups. This clearly indicates the effect of confounding. If a drug can reduce both liver fat and inflammation, these two kinds of response would differ much from that in the placebo group, resulting in a false association. This is not to say that MRI PDFF response has no value. We just need to remember these two lessons. First, the meaning of MRI PDFF response is drug-specific. We need to determine its role in all new treatments. Second, we must not mix the active treatment and placebo arms when evaluating the MRI PDFF response, or one may end up with false associations. Similar to blood steatosis scores, imaging techniques also have their own confounding factors. Abdominal ultrasonography may be difficult to perform in obese patients and those with high riding liver. Focal fatty sparing is common in Nafld patients and can result in inaccurate assessment of hepatic steatosis and difficulties in distinguishing it from malignant tumors. Some studies also showed that the assessment of hepatic steatosis is less accurate in older patients and those with more severe fibrosis. Both CT and MRI are affected by hepatic iron content, though there are MRI techniques to correct for that reliably. Besides, hereditary hemochromatosis is rare in the Asian population, making this less of a concern. For controlled attenuation parameter, both the failure rate and accuracy may be lower in obese patients. To extend the discussion further, the focus nowadays is how to identify patients with fibrotic Nash, because this is the population clinical trials want to recruit, and it is expected that this will be the target population for treatment when new drugs come to the market. One of the most extensively validated tests is the FAST score, which combines CAP and liver stiffness measurements by VCTE, as well as the AST level. We and many Asian investigators contributed to the validation cohort. At cutoffs of 0.35 and 0.67, the score had 90% sensitivity and 90% specificity to rule out and rule in fibrotic Nash respectively. Can we use the score to monitor treatment response? At the recent EASL meeting, we reported a secondary analysis of the semaglutide study. Over 72 weeks of treatment, semaglutide demonstrated a dose response improvement in the FAST score. Importantly, all three components of the FAST score improved with semaglutide treatment, suggesting an improvement in not only hepatic steatosis, but also neck pro-inflammation and possibly fibrosis. Compared with placebo, semaglutide at a dose of 0.4 mg daily reduced the FAST score by more than half by week 72. Interestingly, in both the semaglutide and placebo arms, patients with improvement in the FAST score were also more likely to have improvement in the Nafld activity score and resolution of Nash. Overall, the area under the ROC curve of the FAST score response to predict Nafld activity score improvement was 80%, and the optimal cutoff to predict histologic improvement was a 0.2 point reduction in the FAST score. In summary, Chairman, ladies and gentlemen, we want to detect and quantify hepatic steatosis for the diagnosis of Nafld and assessing treatment response. Abdominal ultrasonography is widely available and is reasonable as the diagnostic test in the majority of cases. Simple steatosis scores are inexpensive and can be applied in large epidemiological studies. MRI-PDFF is the best available non-invasive test and can serve as the gold standard. However, there is great interest in seeing whether continuous CAP and the other new ultrasound techniques are reasonable alternatives for MRI-PDFF. To do that, we must confirm the reliability of the new non-invasive tests as monitoring tools and correlate the measurements with histology and clinical outcomes. Thank you very much.
Thank you, Professor Vincent Wong. It was a pleasure listening to the new data from you. While we wait for questions from the panel, I have just one question. There are several areas in the liver where you will have differential fat deposition, and is the continuous fat assessment by CAP should be extended to different ribs or different regions, or you okay with one region?
Okay, this is an excellent question. Now for our VCT examination, the area of interest would be a 4 cm long with a diameter. If we see that as a cylindrical cylinder, then the diameter would be a 1 cm. So it would be a reasonable core of tissue for assessment, much bigger than that obtained from liver biopsy. However, I would agree that the patchy distribution of fat compared with fibrosis would be even more extensive, and therefore the variability over examination of different parts would be considerable. Now, I think it would be a very interesting question to see whether placing the probe over different regions would yield more reliable results at the end of the day. And this certainly warrants further studies. After all, this is a new technique, so many studies ought to be done.
Okay, thank you. I will hand over to Professor Lauren Castell for rest of this session. Lauren, please.
Thank you, Chief. So now let's move to the next presentation. And congratulations again, Vincent, for the excellent talk. So the next talk is about risk assessment of HCC development based on non-invasive surrogate. And it's my pleasure to introduce my European colleague and friend, Professor George Papatheodoridis from the University of Athens Medical School. George, please.
Thank you, Lauren. I would also like to thank the organizing committee for this very kind invitation. It's a pleasure and honor for me to participate in this APASL webinar. Let me start sharing my slides. Okay, I hope it's okay now. So we are going to discuss the risk assessment of HCC development based again on non-invasive surrogates. These are my general disclosure information, but I don't have anything to disclose specifically related to this presentation. So we all know that the vast majority, 90% or more of HCCs, develop in patients who have an underlying cause of liver injury, and by far chronic infections with hepatitis B or C are responsible for the underlying cause of liver injury in the vast majority of cases, more than 80–85%. Of course, it is also well known that the predominant underlying cause of liver injury in patients who develop HCC may differ across different parts of the world. So in developed countries with high HBV endemicity, HBV infection is considered to be the predominant cause. In developed countries with low HBV endemicity and high or intermediate HCC incidence, HCV cirrhosis was considered to be, at least in the past, the predominant cause. Now the situation may be changing due to the development of very effective agents that achieve HCV eradication and the development of several national plans for eradication of HCV. And in developed countries with low HCC incidence, alcohol was used to be considered the predominant cause, but now in most developed countries, at least Nafld is also a rising underlying cause of liver injury in patients who develop HCC. At the same time, we should keep in mind that among patients who are at increased risk for HCC, the absolute risk, the absolute yearly incidence is not the same. So, for example, it's increased in all HBV carriers, but the absolute incidence is not very high, as you see in the slide, approximately 0.2 per year, but it is highest in patients who have developed cirrhosis due to hepatitis B. It is considered high, a little bit lower than HBV cirrhosis in patients who have HCV cirrhosis, stage 4 primary biliary cirrhosis, and probably in the same range, the risk of HCC is for patients who have other types of cirrhosis. But within each cause of liver injury, there are several factors that affect the HCC risk, and I'll show you the example of chronic HBV infection that has been most well studied among other causes of liver injury. It is a predominant cause of liver injury for HCC anyway. So for chronic HBV patients, we know that there are several factors that are related to liver disease activity and to viral activity that affect the HCC risk. There are very important factors related to the severity of liver injury, severity of fibrosis, development of cirrhosis, and of course there are always several factors related to the host, age, sex, family history, and other comorbidities. And we also have treatment, so we give treatment to the diagnosed at least patient. So we know that for chronic hepatitis B, even the old agents like lamivudine reduced, not eliminate, but reduce the risk of cancer. We also know that there may be difference among the different treatments we use. So for example, for hepatitis B, there are several controversial, I would say, still reports between differences between tenofovir and entecavir. Tenofovir, at least according to some Asian countries, may be associated with lower risk compared to entecavir, but this is not an observation that has been confirmed in all Asian countries, and it has not been found in any, at least European study. Prolongation of treatment, regardless of the treatment, seems to decrease the annual ACC risk. So when we have a group of patients, we need to know how long they are treated. These are our data published some years ago. You see that there is significant reduction in the yearly ACC incidence in patients who start with high ACC risk, those with compensated cirrhosis. Similar data, I would say, have been reported from Korea. Let's concentrate again on the right side of the slide in the cirrhotic patients. Here you see that the annual ACC risk is arithmetically lower, not statistically lower if we split the treatment period at 5 years, but still from 4.2%, it goes down to 2.8%, smaller study. But even in that study, if the period was split at 7 years, then the difference became statistically significant. So the trend is here. And we also know that patients who achieve HBs antigen loss have a much lower risk of ACC, particularly if HBs antigen loss is achieved before the development of cirrhosis and before the age of 50. And even among treated patients with oral antivirals, the few cases who achieve HBs antigen loss are almost no or negligible, I would say, ACC risk. The risk is intermediate in those who remain HBs antigen positive but achieve persistent HBV DNA undetectability, and it's highest in those who remain HBV DNA positive. And in addition to the treatment for the liver disease itself, we may have other treatments for other diseases that can affect the ACC risk. For example, there have been several reports about the protective effect from statins. There are also several reports about the protective effects of antiplatelet agents, particularly in chronic hepatitis B patients, but also in other causes of liver injury. So we have a very complex environment, many factors that can affect the ACC risk. And in this complex environment, we should try to make a risk assessment, at least in this lecture, based on non-invasive surrogates. So in my eyes, non-invasive surrogates can be separated into 3 groups. Non-invasive biomarkers of ACC risk itself, non-invasive biomarkers of liver fibrosis severity, which were elegantly discussed by Professor Castell before, and the ACC risk scores. So non-invasive biomarkers of the ACC risk, we all know that there have been several reports about germline genetic variants in viral hepatitis-related ACC, mainly through GWAS studies and the identification of specific single nucleotide polymorphism. Similarly, germline genetic variants in metabolic-related ACC, the most well-known is the variants of the gene PNPLA3, but other genes as well. And there are several studies reporting differences in the level of circulating biomarkers, cytokine, cell-free DNA species, and others, reporting some, at least, difference in the ACC risk. But I would say, because we don't have the time to go into details for these studies, such markers might be proven to be useful for individual ACC risk-based screening in the future, but they are not widely validated yet, and therefore they are not ready for clinical practice. So moving to the non-invasive biomarkers of liver fibrosis severity, you saw the list is endless, I would say. First, combine epidemiological, serological markers of fibrosis. I don't want to name all of these markers, and the list, as I said, is endless. Many of them were discussed before. So many markers developed for different types of diseases. And then we have, of course, liver elastography. I would say in our areas, FibroScan definitely is the most well studied, and shear wave is becoming more popular, at least in radiologists. But I don't want to give you data about these non-invasive biomarkers and the ACC risk, because as we already discussed, these have been mainly studied for the assessment of liver fibrosis severity and not of the ACC risk itself directly. Of course, there's mostly reliably, as you heard, for the diagnosis of cirrhosis, perhaps even advanced fibrosis, which, of course, is strongly, at least the presence of cirrhosis, strongly associated with the ACC risk. And some markers, as we're going to see later, especially liver stiffness by elastography, are included and are used in some ACC risk scores. And finally, we have the many efforts for the ACC risk scores. And what are these scores? They try to differentiate patients according to their ACC risk, but for clinical practice, I would say they should mainly differentiate patients who have at least a minimum ACC risk and need surveillance, and those who have no or negligible ACC risk and need no surveillance. This is the most practical aspect of the ACC risk scores in my eyes. And how they developed, we start with a derivation cohort, a cohort of a patient that fulfills some criteria. In that cohort, we identify independent ACC risk scores. Then we develop the scores using weighted risk factors. Then the score undergoes discrimination, calibration, validation, analysis, and ideally, it should be also tested in an independent validation cohort. One of the hot questions is when ACC surveillance is not recommended, and I'm not sure we have very, very strong, clear data. The recommendations are based on decision analysis, cost effectiveness models, and very often on expert opinions. In Europe, at least, ACC surveillance is not recommended in child C cirrhosis, except for patients on transplant list, in cirrhotics with an annual ACC risk of below 1.5, and non-cirrhotics with an annual ACC risk of below 0.2%, and there is no age limit. So the ACC risk scores can be differentiated into those which developed for patients with specific chronic liver disease and those who developed in patients with any or some at least chronic liver diseases. Let's start from the non-specific ones. And I would say the first effort for the score development came 7 years ago from this address ACC model. It came from a very large cohort, almost 35,000 patients. 46% had ACV. There were 18% of the patients who had Nash or cryptogenic cirrhosis and alcohol cirrhosis, and fewer patients with other types of liver injury. As you see, very, very few patients with HBV. And the area under the ROC curve, I would say, was moderate, around 0.70 for just 1 year ACC prediction. Age, diabetes, race, etiology, sex, and severity of liver disease were included in that address score. And a few years later, we had the Toronto ACC risk score, which included age, sex, etiology, and platelets. It came from a cohort of around 2,000 patients. As you see, again, 42% had ACV. Here we had around 20% of patients with chronic HBV infection and other causes of liver injury. The area under the ROC curve was slightly better, around 0.75. As you see, there was a good separation according to the risk of ACC and the ACC incidence. We had also a score specifically for alcohol and Nafld, large cohort from more than 23 patients, again, only cirrhotic patients, and this ACC risk model included age, sex, BMI, diabetes, platelet, albumin, and the transaminases, offered an area under the ROC curve around 0.72-74, again, patients with cirrhosis. So the first all scores were focused in patients with cirrhosis, for whom I would say that the scores are not very useful in clinical practice, because it will be very, very difficult not to have cirrhotic patients under surveillance. So it's fine to have a risk prediction for our cirrhotic patients, but I would say as clinicians, it will be very, very difficult not to have our cirrhotic patients under surveillance regardless their risk. The only cirrhotic patients that may stop surveillance after a while are the ACV patients who achieve ACV eradication. So in this slide, I will show you the three main efforts for Hcc risk scores in patients with ACV, particularly ACV advanced fibrosis or cirrhosis. Here is the first such score which developed for more than 45,000 patients from the VA veteran cohorts. And the authors developed three different Hcc scores, one for the non-cirrhotic patients, the same with or without SVR, and one for cirrhotic patients, slightly different in those who achieve SVR and those who do not. Then, very recently, we had a score specifically designed for patients with advanced fibrosis or cirrhosis and SVR after DAAs. And here we have two different scores in that study, one based on transient elastography and one based on FIB4. And they all offered groups of patients with score 0 who had no or very, very low Hcc incidence. And finally, there was another score from a French group coming from a smaller, I would say, cohort, around 800 patients, all with ACV cirrhosis, and they developed machine learning algorithms different for patients who do not achieve SVR and those who achieve SVR. These were all, again, patients treated with DAAs. So for these patients, we may have benefit from the scores, but I would say even these scores are not ready for clinical practice yet. And very recently, the group of Professor Jin-Ling Hu developed a large collaboration in which we and other groups also participated, and they tried to develop the universal score. It was called AMAP. The cohort was large, 17,000 patients, the majority of Asians, but around 29% Caucasians. As you see, the cause of liver disease was HBV predominant, 75%, ACV 20%, non-viral hepatitis only 4%. The area under the ROC curve was, I would say, very good, above 0.80. And more importantly for me, the cutoff of 50, the cutoff for the low risk group, offered an excellent negative predictive value, 99.5% for 5-year Hcc risk prediction. And then we move to chronic hepatitis B. I will show you a few slides because this is the area in which most of the scores have been developed. And here you see the main scores which developed for untreated patients. These are all scores from Asian cohorts. You see the countries, most of them from Hong Kong, Korea, Taiwan, one of Singapore, of China. You see the score parameters, they differ slightly, but many of them include factors that are associated with viral activity like HBV DNA levels, ALT levels, the antigen, and of course, many basic epidemiological parameters like age, sex, and others. And then we have scores that have been developed from cohorts of treated patients treated with oral antivirals. As you see, again, almost all scores except the PACE B score, which we developed from a large group in Europe. All the other scores come from Asia, the same countries. But if we notice the score parameters of these scores, we will see that they are very similar. So all scores include age, of course, all but one includes sex, and all scores include one parameter of liver disease severity, either liver stiffness or platelet or cirrhosis itself. So which are the key characteristics of the Hcc score? In my eyes, the most important characteristic that is mostly relevant for our clinical practice is the negative predictive value of the low Hcc risk cutoff, because this will identify the patients who remain without Hcc surveillance and their risk for developing Hcc. Also, the simplicity and how easy to use the score in clinical practice are very important. The area under the ROC curves are also important, of course, and the proportion of patients in the low-risk group. Here I show you a summary of some independent studies in which some of the scores have been evaluated, and as you see, many of the initial old scores like CAG, Hcc, Cu, RICH-B have great variability in the areas under the ROC curves. In some studies, these areas under the ROC curves go below 0.70, which I would say are non-acceptable areas under the ROC curves. And only the most recent Hcc scores that developed in treated patients like the page B, the modified page B, have always provided in independent studies areas under the ROC curves 0.70 and above. And most importantly, the negative predictive values, you see again great variability in the old scores, and I would say stable, good negative predictive values in the recent score, page B, modified page B, 99% or above for 5-year Hcc risk prediction. This is the page B score, which is recommended by the HPV, EASL, and ACC EASL guidelines. It's very simple, I would say. In fact, we don't have even to remember the score and the group and the numbers. Just this sentence: males above 40s, females above 70s, those with platelets below 200 or 100 millimeters, and age above 40s for 200 or 30s for 100,000, or males have moderate to high risk and they should remain under surveillance. The score has been now validated in more than 60,000 patients from Asian cohorts, more than 5,000 patients in Caucasian and mixed cohorts, and they always perform good, at least for negative predictive value at 5 years Hcc risk prediction. So in conclusion, dear colleagues, the Hcc risk mainly depends on the severity and the cause of liver disease, but epidemiological factors are also very important. Age is more important than sex. Chronic hepatitis B has been mostly studied. The Hcc scores can be useful depending in the chronic hepatitis B setting. The page B is one of the simplest and the most well-validated Hcc score, and the only score included in the clinical practice, in some clinical practice guidelines so far. And the efforts, including risk scores for specific Hcc risk assessment in other settings, are on the way. They will be useful, at least in HCV patients who achieve SVR, and I would say in patients with alcoholic liver disease, and very important for patients with Nafld, but they are not ready for clinical practice yet. Thank you very much for your attention.
Thank you very much, George, for your presentation. We have time for questions. Any question from the panel? Maybe before we have questions, I would start with one question. So in clinical practice, in HCV cirrhotic patients, now cirrhosis is mainly defined by non-invasive tests, especially liver stiffness. And you observe usually, I mean, with the new treatment, most of them are cured. And we observe a decrease in liver stiffness, but still the recommendation of the guidelines are to monitor these patients. Could you comment on this? Because as you mentioned, the screening is cost effective at a certain incidence. But we know that with the cure of Hep C, the incidence decreases, even though some cofactor like alcohol or overweight or metabolic factor are still competing factors. So how do you do in your practice?
I would say that we still continue to at least recommend Hcc surveillance in all our HCV patients who had cirrhosis before treatment, even if they achieve SVR. We know that they don't remain under surveillance forever, most of them. I'm not sure if they have to follow all of them. For example, if I had a young drug addict of 25 years of age who had a FibroScan of 15 kilopascal before treatment, and then we cure the patient, and liver stiffness goes down to 8 or 7 kilopascal if he still needs treatment. But we have to see some data. For example, for hepatitis B, we know that we have published that after year 5, if the patient who had cirrhosis by liver biopsy proven before treatment, if liver stiffness goes below 12 kilopascal after year 5, then the Hcc risk is significantly decreased, but still remains higher than the cost effectiveness of surveillance. So it is decreased, but we should keep this patient under surveillance. So we need to identify the actual risk, not if it's just a reduction or not. And perhaps this depends only on other characteristics of the patient, not only of the liver stiffness.
Any other questions?
Yeah, George, may I make a comment about the risk score? We all know that hepatocellular carcinomas is divided into different stages. And most of the risk score analysis does not really take into considerations of the staging of the HCC and the outcome of the HCC. And the purpose of surveillance at this stage, we want to detect early HCC. So I'm not too certain about all these risk score and so on, because most of these studies does not take these important points into considerations, and that is early HCC, and or the survival of those HCC was not mentioned. And
yes, thank you. This is a very important point. I completely agree with you that the stage of ACCR diagnosis is very important. However, I have to say that at least in Europe, the patients who are under treatment, they are under surveillance. So almost all ACCs are diagnosed at early stages, either early or intermediate stage. In chronic hepatitis B, we just presented this data as an abstract form. We are going to publish from the Page B cohort. So the stage of ACCR diagnosis is definitely much earlier than any reported studies so far, and the survival is really very good. But I agree with you that in many studies, this is a parameter that should be taken into consideration.
in fact, is there data in the various regions about mortality incidence ratios of the HCC from the cancer statistics, whether you are seeing the impact on the mortality incidence ratios for HCC?
Yeah, we haven't studied that, and in Greece we don't have such access to national, let's say, statistics, so it's difficult to assess. But whenever we made, let's say, in our center comparison into the survival of ACCs, which are seen in the recent periods and some decades ago, the survival now is much better.
Okay, thank you, George. Now we move to the last presentation, that is a case summary that will be given by Dr. Kim before we close the session.
Part 2, Case Progress and Summary. After baseline assessment, the patient was treated with entecavir as the first-line antiviral. An endoscopic examination revealed no varices. Indeed, his LSPS score indicated that the patient was at low risk of varices. The patient had an intermediate risk of HCC development based on LSM Hcc score, and a high risk according to the modified Page B LS model. The patient experienced a decline in liver stiffness from 18.2 kilopascal to 14.5 kilopascal after 1 year of antiviral therapy. His ALT level normalized and HBV DNA became undetectable, but he remained HBe antigen positive. At the time of complete virological response, the modified Hcc score could be calculated. The patient had a 10% risk of HCC at 4 years after achieving complete virological response. After 5 years of antiviral therapy, the patient's ALT remained normal. He showed HBe antigen seroconversion, and his HBV DNA was undetectable. The liver stiffness value had further decreased from 14.5 to 7.2 kilopascal. At this stage, the KHB and SAGE-B models can be used to predict the risk of HCC development beyond 5 years of antiviral therapy. The patient had an intermediate risk according to these two models. Unfortunately, after 8 years of antiviral therapy, the patient developed HCC. The stage was BCLC-A. His ALT level was normal, and his liver stiffness value slightly decreased from 7.2 kilopascal at 5 years to 7.0 kilopascal at 8 years. A right hepatectomy was performed. The patient has been on antiviral therapy for 11 years. His ALT level is normal. He has seroconverted to HBe antigen, and HBV DNA is undetectable. The patient's liver stiffness and CAP values could not be determined because of the right hepatectomy. The patient is now under regular surveillance. Thank you for your attention.
Okay, thank you for all the professor and everyone who attended today's wonderful lecture and discussions. With today's APASL webinar about mechanism and non-invasive assessment of liver fibrosis and the steatosis, I think we have got lots of knowledge. And finally, I'd like to advertise the next APASL webinar at September 15th. The next topic is microbiota and liver disease. See you all at next September 17th. Thank you, everybody. Bye.
Thank you.
Thank you.
Bye. Thank you. Goodbye.
Thank you.
Thank you very much. Thank you.